This podcast is brought to you by Conquer Cancer, the ASCO Foundation. Our mission is to accelerate breakthroughs in life-saving cancer research and empower people everywhere to conquer cancer. You can help by donating at conquer.org/podcast. Welcome to Your Stories, a podcast where we hear candid stories from people conquering cancer. I am proud to be your host, Dr. Dawn S. Dizon. In 2022, one of our most popular Your Stories episodes was a conversation between myself and Dr. Karen Winkfield. Dr. Winkfield is the executive director of the Meharry Vanderbilt Alliance, a Biden-appointed member of the National Cancer Advisory Board, and one of the country's leading experts in advancing health equity. In this episode, Dr. Winkfield and I talk about the past and present impact of structural racism in healthcare, including how those barriers affect Black people with cancer. Dr. Winkfield unpacks why cancer risks are higher and survival rates are lower for Black people and addresses the health disparities facing people from disenfranchised communities. She also shares solutions for advancing equity in cancer care, including how and where structural change is on the rise. These topics remain as relevant as ever, so we are re-releasing this episode to highlight the lasting importance of addressing health disparities and working to eradicate structural racism in cancer research and oncology care. Please enjoy and share with your communities.
So I know you're based in Nashville, and I also know that you travel the country engaging communities in important conversations about how to implement change and also break down barriers that they might have locally and the ones that we also see nationally. The barriers that, keep racial and ethnic minorities and other underserved populations from equitable healthcare. Why don't you take this opportunity to tell us about that work, that important work that you do?
The importance of the work that I do is centered around engaging the communities that oftentimes are underrepresented, excluded, disenfranchised. And yes, that does include racial ethnic minorities, but it is very inclusive. We know there are issues in rural communities, with LGBTQ plus communities, with adolescent young adult community with respect to accessing healthcare. So this conversation, while I hope we're going to frame it around the Black population, because as you've stated, the Black population has some of the worst cancer outcomes. And in fact, we are recording this during Black History Month. While that may frame some of the conversation, we do need to keep in mind that the issues are not just specific to the Black population. And so one of the things that is really important about the work that I do is it helps us to hear from the voices of the communities that are the most disenfranchised. It's boots on the ground. It's having conversations with communities. And yes, while I'm based in Nashville, I had been in Boston. I had also been in Durham, North Carolina, and Winston-Salem. The Black community is not monolithic, just the same way that any other community. So it's not a one-size-fits-all. And the opportunities, barriers, issues that were specific to the Black diaspora that was in Boston is very different from what I experienced in Winston-Salem, which is very different from what I've experienced in Nashville or what I hear from my colleagues in California. And as I travel, hearing about the differences in terms of what are some of the barriers and therefore what are some of the opportunities that we have to help uplift populations helps us to recognize that the strategies that are implemented must, in fact, be designed around the communities we hope to serve. Again, you can't just lump everybody in the entire nation into one big bucket. You have to say what's happening locally. And this is why I like to use the phrase, think globally, but act locally. Because while this issue related to the African American and Black population of the United States, it is broad. It's across the board where we see, worse outcomes for cancer, in some particular cases, worse incidents or more incident cases. It is a global issue, but we have to figure out how to implement change on the local level. We convened a panel of experts from around the country a couple of years ago to discuss where some of the gaps in cancer care are for lots of different types of disenfranchised communities. And in January of last year, 2021, we actually published a paper that was specifically outlining an actionable framework for reducing healthcare disparities in the United States. It did talk about the importance of thinking locally, but it gave a broad evidence-based framework that individuals who are truly interested in making a difference in their communities, they have something to go to. There now is a go-to paper.
I think that's such an important concept that you bring up about the idea that minority communities in the sex and gender community, we typically, and I've come to embrace this, it's a sexual and gender minoritized community, because it's not like we wear,
Yes.
a lesbian, trans on our sleeves that people's like, oh, yes. So in a sense, it's the system that has minoritized that community. But yes, none of these underserved communities are monolithic. So, it's, in a sense, speaking globally does work. But when you're giving those talks locally, do you ever get the sense of sensitivities and maybe even landmines so that you're either going to confront or you need to try to avoid? Is that ever something you think about on a local level?
That's an interesting question. One of the things that I've been very intentional about, even in my work with ASCO, the American Society of Clinical Oncology, in some of the work that I do to raise awareness, is the importance of seeing the person who's in front of you. And so I use this concept of humility. A lot of folks like to say cultural competence, which I cannot stand, because it implies that you are going to get it all, that you have, watched a 20-minute video and now checkbox, you are now competent.
Right.
This coming in with this concept of humility, cultural humility, where you are saying to this person sitting in front of you, I may not know you that well, but I'm interested. Help me understand your perspective. Help me understand the things that you value. And frankly, if we do that to each and every person and with each and every person, it doesn't matter, what their sexual orientation or gender identity or what their race or ethnicity is. We are asking that individual what their concerns are. But that does require a systemic change. Just even asking the question, allowing people to self-identify. You very well know that most institutions do not even capture SOGI data, right? Sexual orientation, gender identity. We are still not getting race and ethnicity data correct. So we've got to look at each individual person. That will avoid some of the landmines that can come out of making assumptions about a population or a people, and allow people to self-identify. I'm laughing a little because when I was in Boston, we had a very large immigrant population. And there was a patient who had come in and was asked to meet with a nutritionist after following their cancer diagnosis. And the nutritionist said, well, you need to really be careful about not eating so much, fried foods and all of these things, an African-American gentleman. But it turns out that this African-American gentleman was actually African. And so his diet was comprised of mostly, fruits and vegetables. He happened to be pescatarian, but there was an assumption made that this Black man sitting in front of this healthcare provider ate horrible food and just wasn't, into their nutrition or whatever it is. And it just cracks me up. So I think we need to be very mindful of the fact that, again, thinking globally can indeed be problematic if we're not sensitive to the fact that we must have that cultural humility, that we must be culturally appropriate. And that requires looking not only locally, but also on the individual level.
I think so much of what you're saying is so relevant. No one walks into these positions or into this work with the answer. But right. I think your point is so critical because we all need to start asking the questions. Yeah. So I absolutely think that I love that. All right, moving on, my friend. As oncologists, we know that some people, no matter their race or ethnicity, have biological markers that make them more likely to get cancer. If you go back to the fact that Black people who make up 13% of the US population lead in cancer death rates in America, what are some of the things that people need to know about why Black people are less likely compared to white people to survive cancer?
Yeah, this is a big question. So If you look at the data that's collected, Blacks have the worst cancer mortality of all racial and ethnic groups, in fact. Probably the only group that we have less information on in terms of race ethnicity is our indigenous populations, because oftentimes we're not collecting their data appropriately. And we know that they also have been a very highly disenfranchised and excluded population. So I'll state that. But listen, we've got to look along the entire cancer continuum about where the issues and the gaps fall in terms of healthcare. There's a lot of distrust in the healthcare system for individuals who are Black, particularly those who are descendants of slaves, because they have been excluded. And we understand the structural barriers that have been placed. If we think about prevention, screening, diagnosis, treatment, survivorship, and end-of-life care, there are gaps all along the entire care continuum. And the way that our healthcare system is set up is problematic because we do not pay the healthcare system for preventive care. Okay. So we pay providers to treat disease. We do not pay providers to work on prevention. And that's a massive issue. There are the top two modifiable risk factors for the development of cancer are smoking and obesity. If we take the latter, if we look at the Black population, 70% of the Black population in the United States is obese or overweight, which means that their cancer risk is much higher. The risk of them developing cancers is much higher. You think about for breast cancer, colorectal cancer, where we know that there are these clear connections, prostate cancer, maybe less so, but certainly we know that with them, there's a risk factor with obesity. So, in general. And then smoking, which Black men have one of the highest smoking rates in the country. And they're being targeted, right? The advertisements, et cetera, all of that. There's specific targeting for that. And Black men have the highest rates of many of the cancers that we are really working hard, lung cancer, prostate cancer, to really reduce risk for. So that's on the prevention side, but it also means, are we getting screening? And, the COVID-19 pandemic has highlighted the access issues for people who may not have ever noticed that they were there before, right? You and I have been working in this field for a long time. We understand the barriers have existed, but some are like, oh my goodness, wow, this is novel. Well, no, it's not. Right. So there are these gaps, and a lot of it is related to socioeconomic status. Let's put that out on the table.
Correct.
Wealth matters. In this country, the capacity, the ability of individuals to access healthcare is absolutely tied to socioeconomic status, their income, their occupation, and their education. And it's not just education about whether or not you have a degree or not. It's also talking about health education and health literacy. So we'll put that out there. But occupation, if you get paid by the hour and have to travel an hour and a half to go get your breast, your mammogram, for instance, and then have to travel another hour and a half to get back to work, that's half a day. So we've got to think about that. We've got to think about access. We've got to think about the people who may be paid per hour. And if they miss that half a day of work, they're not going to be able to put food on the table. Because remember, in the United States, we do not pay people living wages. And that disproportionately impacts the Black community because of structural racism. Oops, did I say racism? I did.
Yeah.
So we've got to be clear. There are barriers built into the system that prevent Black Americans from accessing the healthcare at the points where they potentially could have improved outcomes. We know early detection is key. We know that screening and prevention is the way to go in early detection. But we're even struggling with getting people there because of the systemic barriers.
Yeah, I think that again, the point about wealth just meaning so much in terms of access in this country and, high income countries all over the world. You and I have sat with people who underwent screening, who traveled the 1 hour, who got off work from their hourly job and then were diagnosed with cancer. And the look of absolute fear, not even because, am I going to live through this? It's more like, how am I going to do this if I cannot work?
Yes, that. To the point where I've had patients tell me that, breast cancer patients would come up to me and say, I elected to get a mastectomy because that was the only way I could foresee doing this for my family. If they had to get radiation therapy, that at the time was a 6-week long course of treatment every day, they said there was no way to do that. So they elected to have a mastectomy so that they could go back to work sooner, it friggin' blows my mind, right?
Right.
That's not an easy surgery.
Mhm.
And yet, some people were forced to do it and go back to work
Mhm.
after just 1 or 2 weeks of being out.
Right. Right. And I think that, the trajectory of the cancer experience, it's all builds on each other, so that one decision you make because you need to feed your family
Mm.
has repercussions years and years later on your body image and how you see yourself in the society, how you see yourself in your family, how you define the role you play. It's all together. When I think about, and there's this term that maybe we can get into a little bit of intersectionality. It's true. The struggle is the same with the folks I meet who are white, who are just socioeconomically disadvantaged, and the struggles that they face are the same, yet they're very different as well. I think you're right. It is very complicated. And applying that local lens to this issue, I think that has to be one of the things that you spoke of, but it's just so important.
Yeah. Your point about intersectionality is really important. And it's just understanding how the different categories or communities that individuals find themselves in. And I'll say communities because I think that's where we really need to focus in on. If, for instance, an individual is a member of the Black community, that has with it all sorts of connotations from a social context. Imagine then if they're both Black and of the LGBTQ plus community,
right?
That adds another layer of complexity.
Uh-huh.
And what if that person also lives in a rural setting? Like, hello.
Mm-hmm.
All three of those things, being part of the LGBTQ plus, being Black, and also being in a rural community may put them in a situation where they are actually may have the lowest capacity in terms of economics than anyone else, right? And I say that because all three of those categories are overrepresented in poverty, or they're all
really good point
in lack of insurance.
Yeah.
Right.
Yeah.
So I think that these situations can compound, one on the other. But even if you look at rural communities and you look at rural whites versus rural Blacks still have worse outcomes when it comes to healthcare, right? So this is a lot of it, again, is really important not to dismiss any of the communities. But if you start to focus on the community, the community that has the worst access, there have been studies that have shown that if you implement programs to support the communities that have the worst access to healthcare, that it actually elevates healthcare for everyone at that center, in that region, in the state. You may recall, actually, the state of Delaware did that study where what they did was they looked at colorectal cancer screening. They found that African Americans had the worst colorectal cancer screening and said, let's put together at statewide level a program to help improve colorectal cancer screening. And by doing so, and after implementation, not only were they able to raise the colorectal cancer screening rates for African Americans, they also raised it for the entire state. So part of it is, again, thinking about what's the community, where is the greatest need, what can we do, how do we engage that community in bidirectional communication to say what are the levers that need to be pulled? Because as you've stated, that intersectionality, poverty is oftentimes is really the root of many of these issues. And if we can actually provide access for the individuals who are struggling the most, then we have the potential to elevate care for everyone in that region.
I mean, there's a lesson for society right there. All right, moving forward, what do you see health systems doing to help Black patients, and how can we meet those communities? How can we actively meet the communities? And you mentioned the Delaware experience, which is a great example. But what else have you seen and heard of in the work you're doing?
Not enough. Yeah, don't get me started. Wow. So I mentioned that paper that was published in Journal of Clinical Oncology Practice. So
Yes.
JCO Oncology Practice. Again, stakeholders from around the country were pulled together. There are some best practices, some of which had been published in the past. Others are just from boots on the ground experience and kind of show what can be done. Obviously, navigation is one of the things that I am a huge, huge, huge proponent of. We do not have enough navigators. We do not have enough community health workers. We do not have enough lay health advisors, all of them really under the umbrella of navigation. If you think about what Harold Freeman intended with the navigation program, right? So Harold Freeman, this amazing surgeon in Harlem, noticing that his Black patients presented with more locally advanced disease and had worse outcomes, simply by training someone who is from and of the community, a layperson, not a nurse, not a physician, not a PA, someone who's from and of the community, trusted individual in the community, training them about the importance of breast screening, what is mammography, how do we kind of move people through the system, that education piece really being key. He was able to actually improve the overall survival from 30% to 70%. Like what? Overall survival. So navigation is really something that people's like, well, we don't know what the return on investment is. I'm sorry. Like, how about life? How about lives saved? That's a return on investment. But if you want to put a dollar amount on that, then yes, we need to do some of that work and show, oh my goodness, we've been able to improve, people's access. We're not getting people at late stage disease where it costs more money to the system, right? We're catching them early where they might have an early stage cancer that can be cured with either surgery alone or, very little, a shorter treatment course. I don't understand why our focus has to be on the business part of medicine. I know that was a policy decision that came out several decades ago where they've tied our healthcare is no longer a right in this country, right? Yeah. It's now tied to capitalism, and that makes it a challenge. So I do think that there is a programming. Folks can take a look at that paper because, it actually does highlight many of the things that need to be done. But I also think it's really important for individuals and for institutions and organizations to understand what their role is. Because a lot of this is all social justice. Healthcare is a social justice issue. And when we think particularly around Blacks, George Floyd's murder highlighted this for many people in a way that I'm telling you, if COVID wasn't here, we would not have had the same response. Because people were sitting at home with nothing to do because everything was shut down, they got to watch an 8-minute plus video of someone getting murdered, and all of a sudden there's a groundswell.
And you could not ignore it. That was the thing. You couldn't not have seen it.
Yes.
You didn't have the luxury of saying, I didn't see it.
Yes. Yes.
Yeah.
It highlighted, though, the anti-Black racism that still exists.
Yeah.
That's still so pervasive because it started those conversations. And our nation has not had the conversations, and it needs to. Like, the United States needs to just acknowledge, wow, we had slavery for 200 plus years. That was a race-based system. And for 401 years total, there's been disenfranchisement of a specific singular population. Just acknowledging that alone could go a lot towards having conversations that can help to then say, what do we need to now do, right? And so my colleagues and I, after the George Floyd incident, we wrote a paper that said why racial justice matters in radiation oncology. Now, we said radiation oncology, but it could be oncology in general. And there were a few things.
Could be medicine in general, honestly.
There you go. And I've actually given talks to that effect, right?
Yeah.
Why racial justice matters. And again, we talk about intersectionality, but the racial injustices are the ones that have really been problematic and continue to be so in a very profound and open way. It's just ridiculous. I feel like there are some communities that are gaining some leverage, some of it on the backs of what Blacks have done to try to
100%. Yeah.
But it's okay. But I just want to make it clear that this anti-Black racism needs to be dealt with. And so that paper actually did outline a few principles for individuals to really say, I need to learn about this. I need to, how can I advocate? What are the things that I can do? So we've outlined clear steps that individuals need to take. But then we also said there are things that institutions, organizations, countries need to do with the ATIP principles that includes kind of acknowledging and being transparent and really implementing, programs that can really help. So I would encourage folks to take a look at that paper. It's published in Advances. I think it was May or June of 2021.
Let me ask you a fairly provocative question based on all of this. Yeah. So I think everything you said is the truth for sure. When I think about it from an institutional perspective now, having been confronted, and I'll use that word purposefully, confronted with systemic and structural racism in the communities that we are within, and perhaps even in the way healthcare was approached. And let's say that there is now this very heartfelt move to engage, reimagine, re-envision, and obtain input from those communities. One of the things that I think has to be handled sensitively is that outreach, because what George Floyd's murder did was not only bring the flashlight into racism in this country, but it ignited the fire. And I will say this, for lack of a better word, the rage that had been simmering because access to healthcare has been problematic. And we'll focus on healthcare. Access to healthcare has been problematic. Access has been too expensive. Access has been denied. Now the institution is coming to you and say, help us do better. How does that work? When one might have that position within community leaders, for example, saying, you haven't helped me one bit. I've come to you, and now this cancer, we can even choose that. My cancer is advanced because you didn't think to help me one bit. So how does one engage in that highly charged environment that we're all actually still living in?
Done. So let me tell you, while yes, there's a fire ignited, my fear is that that flame is going to go out very quickly. Because
really,
absolutely, because it's not easy work. The work is not easy. I mean, you just highlighted, wow, this has been a community that has been systematically disenfranchised for centuries. And then people are like, so what do we do? We want to help. Okay.
That's it.
Here are the steps. And then they go, like, wait, there's like work? Yeah, there's work. There's repair. There's reparations. And I'm using that word intentionally.
Yeah.
That need to be made. I remember one of the institutions I worked with, I said to them, and this was early in my tenure there, I had been doing some listening tours in the Black community and said, I think what would really go a long way to help bridge the gap, to help people say, man, that institution is really interested in hearing what I have to say as a community, as a member of the Black community, is for you as an organization to simply acknowledge the past egregious activities that happened there. One of which was eugenics, which, as you know, was the systematic sterilization that disproportionately impacted Black women because Black race, who needs them, right?
Right.
Whatever.
Right.
But the community remembered, because eugenics went through the 1970s. I mean, people think it was a long time ago. Oh, to the no, right? Just the same way that Tuskegee ran into the 1970s. Yeah. This is not that long ago, folks. And people like, well, Black people need to get over it. Get over, this is my generation. This is in my lifetime that these things happened. And for institutions then all of a sudden say, oh, look, we need to help the poor Black people. First of all, make it real. And I do think there are people who are in an institution are interested, but first acknowledge that there was past, that there's been a past, that there has been these past egregious activities, that racism has impacted care, that there are still structural barriers like redlining that are creating wealth gaps that continue to grow. And again, it's hard for healthcare systems because you're like, well, I'm not in charge of the redlining. Right? So a lot of times institutions say, well, I can't impact that, but yes, you can, because you have a voice, right? Oftentimes healthcare systems, the larger ones, are some of the largest employers in the region. How are you treating your employees? So let's go to where we do see Black people in the healthcare system. Oftentimes kind of working in environmental services, in kitchen services, maybe medical assistants, front desk staff. If you look at the institutions, have you asked yourself, how are you treating your Black individuals? if those are the same people who are hourly wage earners, or if you're one of those institutions like some of the ones I've worked at before, where you only allow them to work part-time, so they do not have healthcare benefits, despite the fact they're working at a healthcare system. Don't get me started on that, right?
Yeah, 100%. Let me bring this back to another issue, which I think is also really relevant. A lot of our institutions, including the ones that I've been associated with, they have their equity and diversity statements. That the care, okay, you know where I'm going with this. That we will provide care regardless of race, of socioeconomic status. They have it. But then even someone like a physician who's a gay parent can come into that system and meet with discrimination. And it's such an interesting thing to say, this is what you say, but this is the real lived experience. Yeah. And then to have leaders come in and say, well, in this specific case, me taking my daughter, them asking for mom's name, me saying there's no mom, them asking for adoption records. Oh, yeah. Oh, yes. Oh, yes. And then me taking this to leadership saying, this is a problem and here's why. And them saying, well, she did have a mother. So there's what's posted. Right. And then there's the lived experience. So I wonder, that's my example.
Yes.
I'm sure you might have yours, but talk about that. Talk about holding institutions and what the community, not even individual, what can the community do to hold institutions to what they have posted? And is there a way for us to do that together?
Oh, so you are absolutely right. Every single institution, healthcare institution has their mission and vision statement that is in some way suggestive of them being inclusive. But we know that's not the case. And it's definitely not the case with respect to cancer care. If you think about the fact that there are some of our very large, prominent cancer centers that do not accept Medicaid, right? Crazy. So what you're saying is, wait, so we are available and open to everyone. We want to be inclusive, except for the poor people.
If you have the insurance I take.
Right.
Obviously.
Or except for the disabled, right? Because Medicaid is not just for poor people, right? So that's one thing. So I do think that when it comes to this aspect of being culturally appropriate and providing culturally appropriate care, that the training, quote unquote, that institutions implement can't be a one and done. There has to be continual reminders. There has to be continual confrontation, if you will, of saying, man, listen, these are the things that are happening. And so when you have a leader who comes to you and says something ridiculous like that, they need to be immediately, there needs to be some mechanism by which they need to be taken into the corner, right? Yeah. And not just scolded, right? And it needs to be done in a way that, there is some sort of public acknowledgement, because that's the challenge. A lot of this stuff happens in private. A lot of the issues that come up with respect to the barriers to healthcare are done in a private setting, because you're told to call risk management, right? Or whatever, as a patient. And you call risk management, and risk management, takes care of stuff all like behind the scenes. I'm like, no, we need to have a publicly facing health equity report card, period. Yeah.
And that's an interesting idea. That is a really interesting idea.
So there has to be real intentionality in terms of what is it that you're going to measure on a health equity report card, and what are the metrics? And it can't just be around how well people do clinically. I think that's one component of it. And the reason why I say that is because you don't want to ding the institutions that are primarily caring for the disenfranchised and marginalized populations, right? I think about my time in Boston.
Right.
I didn't even know Boston was a majority minority city until I went to City Hospital. City Hospital is caring for all of the patients that other institutions in the region be like, sorry, you're too poor, or you're too black, or you're too brown. And they're caring for those individuals. And because of all of those external pressures, all of the societal barriers, they may have worse outcomes, the clinical outcomes. So you don't want to ding the institutions that are caring for them. So the health equity report card must be on more of those tangible things, or the intangible things that oftentimes go unseen, like, how is leadership, responding to the intersectionality within their own organization. That to me speaks more.
Yeah. I think it's also, you mentioned that, City Hospital here in Boston, is caring for those folks. But the other reason City Hospital is caring for those folks is because that's where the community finds trust.
Yes.
So it's both, it's just like, yeah, you might want to serve that community, but they don't trust you.
Yeah.
You need to recognize that, and then we can approach it. But if you don't even recognize that, then we'll never get anywhere. All right. So we're running out of time. I did want to ask you about the clinical trials issues. Okay. We look at who enrolls in our trials, and it's remarkable, shocking, that few underserved people are still going on clinical trials. So the question to you is, what do we do, and what can you tell this audience about that underrepresentation of Black people on our studies?
Yeah, let me just state in general, we don't do a great job in this country of enrolling in clinical trials in general, right?
In general, correct.
We may have, 9% or so of individuals who are involved in clinical trials in the nation. And so we appreciate all 9% of them, right? We appreciate them so much. But you would think that even with something, as scary as cancer can be, that people might say, I want to consider doing, finding ways that may help improve not only my care, but the care for future generations. But that's not always the case. And when you use the terminology clinical trials, that in of itself can turn people off instead of talking about clinical research or clinical studies, because trial indicates that there is some uncertainty. And while we know that as researchers, if you're doing a phase 3 clinical trial, even a phase 1, any of the phases, that there certainly can be some degree of uncertainty, but it's really about how you couch it. And making sure that individuals who coming in for cancer in particular know that if there is a standard of care option, they will always at least get that. If it's a randomized controlled trial, they will always at least get standard of care. Now, if they're palliative and there's nothing else that they have, then maybe the standard of care is nothing, but they're always going to get the standard of care. And so they will always get some degree of treatment. But it's really important to acknowledge even that fact because of the past, as I mentioned, even the Tuskegee study, which happened well into the 70s. Okay, so there are individual communities that worry about being guinea pigs. So there is some education that needs to be done, at the community level before people have a cancer diagnosis. So one of the things that I've been doing in my engagement activities is to always talk about the importance of research and making sure we're at the table. However, what I hear back from my community members is, I have prostate cancer. I wanted to enroll in a clinical trial and I was never asked. Or, I wanted to enroll in a clinical trial, but they had some weird exclusion criteria. So I wasn't eligible. Again, remember we talked about the obesity thing. If BMI is one of the things that you have as an eligibility requirement and you have a BMI less than 25, you're going to exclude most of the US population. I'm just saying. So you might want to look at that. So part of it is looking at eligibility requirements as well. But let me tell you, there was a paper that was published in the journal Cancer in 2020. And Selwyn Vickers was one of the co-authors of this paper, and it was talking about bias and stereotyping amongst researchers and clinical professionals. And they actually did 91 qualitative interviews, 91 interviews with 91 different individuals from across the different stakeholder groups. And what they found was that the individuals, the researchers, and the clinicians, investigators who actually had bias. Like, duh, right? The reason why I'm talking to patients are saying I'm not even being offered because providers and clinicians oftentimes think that the recruitment interactions with minority populations are going to be more difficult or challenging, or they're not perceived as good candidates. They may not be compliant, right? Mm-hmm. Instead of saying, well, how can we make this easier for the patients? How can we become more patient-centered in the way we design clinical trials, which includes thinking about eligibility, thinking about access? Do we really need that 5th CT scan? Maybe we don't, right? Maybe the patient can get their blood draw closer to home, or we can send somebody to their home, being more patient-centric in the way we do it. So I think clinical research is really one of the areas that I've been focused in on. And you think about, language even being a barrier, right? Don't just make the assumption that because someone does not speak English, they are not going to want to participate in a clinical trial.
I think that's 100% accurate. And I'm actually glad you sort of framed it this way. Their clinical trial is an enterprise, right? And there's multiple steps within that enterprise. And you can't just fix one thing and expect more underrepresented people, more Black people, more gay and lesbian people to enroll in your studies. In the world of sex and gender minoritized folks, we are trying to decouple gender from a cancer.
Yes.
So why does your study say you're excluded if you're not a woman with ovarian cancer? Oh, well, this is a trans man with ovarian cancer. So technically, he can't enroll in your study. Why do you have to say men with prostate cancer? Did you think about that? And, I think it goes to this thing that you also mentioned of that sort of implicit bias, that sort of nothing that we're conscious of, but they guide how we interact with each other. It's that reason why you're looking at this woman, this Black woman saying, no, I'm not even going to discuss the trial because she's not going to do it.
Yes. Yes. Yeah. That there's these automatic assumptions to the point where and look, I am now at an HBCU, right? Faculty appointment, but even in the way that we on the tumor boards, so people were like, this is a 68-year-old Black man or 59-year-old white woman. Why does his or her race matter? Why does the race matter in this discussion? Right? Just the same way. Like, can we divorce gender from the conversation? Can we divorce race, ethnicity, and really, again, hone in on this particular individual and what their needs are?
Right.
It's just lumping them into a category. And so I actually brought that up. And it's funny because we're trained oftentimes in medicine. That becomes part of the history of present illness or the chief complaint. They actually put in all this crap that doesn't matter. It's superfluous. And so we've got to retrain not only the medical students and the residents, but we've got to train the folks who've been in practice. We've got to retrain them because they're the ones who are modeling the bad behaviors in many ways. I think the younger generation is more woke. And so, but it's really important I love what you're saying. And that's a really great example because I have clinicians that struggle. How do I take care of a trans person? I'm like, really? Like,
it's like, well, why don't you just, accept who they are, call them by their name that they wish to be called by and start there. And then you can treat them like a patient or like a person, not even as a patient, treat them as a person. Let's start there.
Yeah.
All right. So to conclude here, Karen, so what research would you like to see within the next 5 years to specifically try to close that gap in cancer care for Black people?
Yeah. I think we've got to move away from the descriptive science that happens all the time. People doing these large database analysis to say, oh, look, Black people are underserved. Oh, look, we don't capture this data. Well, yeah. Well, how about we start to couple that with implementation science? I'm a basic scientist. I'm a biochemist. And back in the day, you could simply kind of describe a protein. Oh, look at this protein, new protein I found. You can't do that anymore. You can't just publish a gene's DNA, what the DNA sequence is. That is no longer allowed. It was early on, but we know disparities exist. There's no need to describe. And so papers and journals that allow people to just write in papers and saying, oh, look what we found. There's a disparity. Well, yeah. How about we now move to the next level? Just the same way that as a basic scientist, you now need to say, what does that protein do? What are its partners? How does it interact? Even kind of potentially think about its structure. So we've got to stop the descriptive research. I really would love to have more community engaged research that's focused on like developing sustainable programming to reduce barriers and explore the implementation of that in different types of settings, right? We talked about the difference of what happens in the Northeast versus the Southeast versus on the West Coast. So you might come up with something that might work in your town, in your region, at your institution. Let's look at implementation broadly.
I love that idea. And I think it's the only way we are going to see progress. I mean, you need to make sure that the leadership understands all the way down to the people who are saying hello at the front desk.
Yes.
If you don't have all of that, if you don't train all of that, you can train all the docs you want to be as sensitive to all of this. It takes one interaction to blow it all up. So I 100% agree with you. Everything that we're doing, we've got to ask the questions about implementation, because if we can't sustain something, if we cannot sustain change, then I worried, like you do, that the flash of activism, some say anger, some say awareness, that's going to extinguish because nothing has been sustained. And I think that's what we need.
Yep, agree.
It's going to get there on the backs of folks not acting in their own interests.
Ooh, boy, that's a mouthful right there. Yes.
I mean, it's like you and I are sort of in this field, but we're taking people with us.
Yeah.
We're taking people with us. We're growing them.
Yeah.
But we're also, you know what? Once you reach that academic echelon where, I mean, I can't believe it. I'm saying where we both are now. It's like you don't need more accolades. What you want to see is change.
There you go.
Yeah.
Love that.
Thank you for listening to this podcast brought to you by Conquer Cancer, the ASCO Foundation. For doctor-approved patient information, please visit cancer.net, which is supported in part by Conquer Cancer donors. Conquer Cancer is creating a world where cancer is prevented or cured, and every survivor is healthy. You can help by donating now at conquer.org/podcast. The participants of this podcast report no conflicts of interest relevant to this podcast. Full disclosures can be found on the episode page on conquer.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.